are back again live from Watany Ophthalmology Summit, and we are pleased to have with us Professor Dr. Mohammed Mughazi, who is a professor of ophthalmology in Ain Shams University. He's also a veterinary consultant at Al Watany Eye Hospital. Hello, Dr. Mughazi.
Hi, Dina.
So we are going to talk today about the challenge of macular hole surgery. You tell us more about that.
Well, it really depends which macular hole you're talking about, okay? And we can divide them into idiopathic holes and myopic macular holes. These are the main holes we're working. And actually the macular hole surgery has gone through a lot of evolution from the stage of just observation, doing nothing. Some have advocated maybe 30, 40 years ago just to do laser to close the hole, of course inducing a large scar. And then with the introduction of vitrectomy surgery, vitreous surgery in general, there was hope for those patients with macular holes. And at the very beginning, the technique was very simple. You go in, you do vitreous, removal of the vitreous, you just induce a PVD, and actually some holes used to close. And then with the discovery of the ILM, and I mean the discovery of the surgical ILM, because ILM has always been there, removal of the ILM, complete removal of the ILM was now, or at that time, maybe I think 15 to 20 years ago, was the key to success of macular hole surgery. I think this was the beginning of the era of the ILM. And then with time, things have evolved more, where the ILM was not just removed, it was inverted to help closure of the hole. And later on, recently, we've seen studies that maybe ILM is removing it or inverting it or just taking it out is dangerous to the nerve fiber layer. So you see, macular hole surgery has gone through a lot of evolution. But in general, macular hole surgery is, although a straightforward surgery, and although most of the patients have a closed hole, the success rate is 90 to 95% now, but still you face some challenges, especially in special situations like if you have a large macular hole, if you have myopic macular holes. These are different scenarios.
Okay, so which brings us to patient selection and the kind of patients that you're happy to operate with, and the others that you need more consultation with preoperatively.
Well, if we take idiopathic macular holes, I usually, the first thing I ask the patients for how long you've been having the symptoms, and to my surprise, most of the patients I discover they have a problem with one eye accidentally. They went for to check their glasses, or accidentally they covered the sound eye and they discovered that the other eye is not seeing well, so they start going to a doctor and seeing what's wrong. And those patients usually have macular holes that are large and been there for such a long time, usually have poor visual acuity. I mean, I'm talking less than 20/200 vision. And those patients usually never improve after macular hole closure. Even if the closure is successful, they usually never improve vision. And usually I tell the patient at the beginning that if we're doing anything, we're just preventing the hole from getting bigger, that might affect further your visual acuity. But at the end of the day, it's up to the patient. Those patients who come early with relatively smaller holes, fresh holes, those patients that really benefit from macular hole surgeries. I have patients who can recover to 6/6 vision after surgery if the hole is caught at the very beginning. Okay, these are idiopathic holes, and of course success rate is very high. If we're talking about myopic macular holes, it really depends, because the pathology in the myopic eye is very variable. We have patients with very high myopia and no staphylomas. We have a patient with moderate myopia with large staphylomas, and staphyloma itself is very variable. You can have a lot of types of staphylomas. So you can have a macular hole on an attached retina, you can have a macular hole with a detached retina, you can have a macular hole associated with myopic foveoschisis or myopic tractional maculopathy. So all of those are really challenging. For me, the indication for myopic macular hole surgery is if it's associated with myopic foveoschisis or associated with retina detachment. But those flat holes, myopic patient with background RPE atrophy, I usually don't touch. I just tell the patient to follow up, because if they develop later on retinal detachment, I would go in. And why I do that? Because the results of surgery in those patients is really poor. I mean, the patient can go in 2100, 2200 and comes out counting fingers. Vision, it's really challenging to work on the macula of those patients. But those patients that I operate, so that I just mentioned, the technique has also evolved, but I think that ILM here plays a key role. It's not an option at all in those patients, because myopic macular holes are really difficult to close, are really resistant to closure, and most of them, they would end up with a flat open hole, what we call a flat open configuration. You cannot consider this a successful closure of the hole. Maybe the retinal detachment is gone, but these patients have a persistent hole. So ILM maneuvering in those patients is mandatory. And of course, using the different stains that we have now, different techniques of inversion that we have now, can really help the closure of those holes. Also nowadays we have the autologous grafts invented by Tamer Mahmoud in the United States. I think this also one of the good options for those patients with recurrent myopic macular holes. I don't have any experience with the buckles in those patients, but I think from what I've seen and what I've read, buckles are mainly for those patients treated with myopic traction maculopathy. But just a hole, I think the buckle will not work well. It has to be, if at all, conjoined with vitreous surgery, vitrectomy.
Okay, and how do you find IOCT, intraoperative OCT, as an adjuvant to your surgery in the OR?
Well, I'm really skeptical about intraoperative OCT for personal reasons and obvious reasons. I mean, personally, I've been working much before the intraoperative OCT was available at the hospital, and my success rate was okay. It's going on with the what I read in the literature. But with the intraoperative OCT, I tried it in so many cases so far, but I didn't think it added me anything. Of course, you can make very nice videos, you can present them at meetings, and people would say that you have the latest technology, but at the end of the day, it did not add neither to my decision making intraoperatively, nor to the success rate of macular hole surgery.
That's very interesting. So what is your preferred technique? What do you go with? What is your standard?
My preferred technique is I do only what I call a fashioned ILM flap. I don't remove the whole ILM. I just fashion it temporal to the fovea and just invert part of it. I think the advantage of this technique is you don't lose the flap, because sometimes if you just invert the whole flap, sometimes with air fluid exchange, with the turbulence that happens, you can lose the flap. The other thing, which is very important, especially in high myopic patients, is you have a reservoir of ILM, because again, those patients, the closure rate is less than idiopathic holes. You might need reoperation, and if you go in after removing the whole ILM, you have a really hard time intraoperatively to decide what to do to close the hole. So if you just partially invert that flap, and you have this nasal part, a reservoir of the ILM, so in case of failure, you can use that reservoir to cover the hole again, and this increases the chance of success. So this is the temporal inverted ILM flap, fashioned ILM flap, or customized ILM flap is my preferred technique in macular hole surgery in general.
Okay, thank you very much, Dr. Moghazi.
Thank you, Dina. Thank you.